Good afternoon and welcome to this month's edition of the Flint Community Webinar, your community resource. I'm watching you all come into the webinar. It's so good to see you. You made it to Friday. You made it halfway through the day on Friday, and we're glad that you decided to come and join us. We have a lineup for you. So you can see on the screen, we've got new faces. We've got faces that are regular contributors, regular trusted messengers here on the webinar, but we're focusing on nursing. This is such a critical role in our community in so many different ways, in prevention, in education, in hands-on clinical care, so many opportunities that we have to benefit from the nurses in our lives and in our community. So we have Nurse T, we have Doc G. We also have Joanne Herman from the Health Department. We have Cecilia Rutherford from Hamilton Community Health Network. And then these are the new faces. So we have Dr. Stephanie Sulia from Mott Community College. Many of you may already know her if you're a nurse and you went to Mott for training. And then we have some folks from MSU. So we have Dr. Leo, and she is from the College of Nursing. And then Dr. Winowicki, who is also from the College of Nursing. And those two are going to start off our conversation for us now, talking about nursing, workforce, self-care. So if they can come on and join us, we'll start this important conversation. Once we've heard from them, then we're going to have a roundtable around the topic of nursing in the community. So get your questions ready, your experiences, and we can jump into that. So I'm bringing in Dr. Leo. So I'll turn things over to the two of you.
Okay, hi everyone. I go by Haya. So I'm a nursing faculty at Michigan State University College of Nursing. I focus on self-care, social determinants of health. That's related to my teaching part. And I have been doing self-care with my nursing students since 2020. And I totally agree that self-care for nurses is really important. Josh, do you want to go next?
Absolutely. I can introduce myself. Hi, everybody. I'm so happy to be here. My name is Dr. Josh Winowicki. I use he, him pronouns. I'm a clinical nurse specialist, an assistant professor in the College of Nursing at MSU. And I also lead the Center for Practice Transformation, which really sits kind of between academia, clinical practice, and our community partners. I'm really excited to be here. Flint is a part of my heart. My husband is an immigrant, but grew up in and around Flint, went to U of M Flint. That is where I met him. So I'm really happy to be here and be back with the community.
Okay, so do you continue with the organizational part?
Yeah, jump right in. Tell us everything you've been learning from your research and what you know about nursing.
Okay, so I think I'll go first. I focus on self-care among nursing students since 2020, and the reason I want to focus on that because they are really stressed out. Like every week when they came to my class, I can tell they are stressed out from their faces. Nursing programs is really stressed out. They got a lot of things to do, and they don't just take classes. They also go to different hospital settings. They work with different type of patients with different diagnoses, with different needs. So a lot of time they did not really have time to think about themselves. According to the survey I collected from my last summer students, even in week 1, their average sleeping hour was less than 7 hours. And that was just in week 1. And in the end of the summer semester, their sleeping hour average was just almost around 6 hours, which is way below than the Sleeping Association. Their recommendation was like you need to have sleep hours from 7 to 8 hours or even 9 hours. But for nursing students, it's really impossible. So their stress level is really high, especially many of them didn't get enough sleep. That's why I have been doing self-care retreat since 2020, and I provide like meditation, mindfulness. I also like have a yoga teacher. She's also a nurse practitioner coming to teach my students how to do basic yoga to kind of get relaxed. And in the afternoon session, uh, it's kind of fun. So I teach my students how to make soaps with essential oils, with dry flowers, using different kind of shape of molds, with different colors. So they were very happy. And the only assignment they need to turn in after the retreat was I asked them to take a picture of the soaps they made that day and post it on their social media account. And I asked them to write best day ever. So I want them to kind of remind themselves in the future when they are really stressed out. They use social media every single day. So I ask them, when you are really stressed out, go back to your social media and look at the soap you made in the retreat and remind you that was the best day ever. Remind you, okay, Haya kind of asked us to do meditation, to relax. We practiced yoga that day. We even made like a stress catcher from CDC website. So hopefully by doing that, they can refresh their mind and relax a little bit. And the reason also I want to do that is because according to different surveys, like between 18% or even up to 50% of new graduate nurses, they quit their job in the first 2 years. I mean, they quit, they choose to leave their nursing career because of stress, because of burnout. So I don't want them to leave. We need nurses. We really need nurses. Everyone gets sick. One day, I mean, eventually we get sick and we need quality nursing care. So they finally finish their nursing program. They pass their board exam. They become a qualified nurse. But because of stress management, they choose to leave their job. I feel, I don't want to see that happen in my students. That's why I focus on that.
Thank you so much, Haya. That's amazing work and super timely. I entered grad school right around the time that you started doing some of those things. And, I think that ingraining those self-care behaviors and those person-centered behaviors really early in training is super important, right? So we can mitigate and prevent some of those things. Before I really kind of start, I was just doing some math in my head, and I think there is probably 150 or 125 years of nursing experience just in the panel, which is amazing. The wealth of knowledge and things that we hold is really important. And I think that venues like this are really powerful to get some of that nursing information out there. Um, so Hyatt's really talked a lot about ingraining these behaviors early in nursing students. And I've had, the wonderful opportunity to work with undergraduate nursing students. I teach now mostly in the graduate programs, and I work a lot with practicing nurses and APRNs. And frequently I find that unless work like Hyatt's has been done in the foundation, it's harder for practicing nurses and grad students to ingrain some of those person-centric behaviors, when I really think that we need some structural organizational changes, right? Because taking care of yourself is often in the same breath in a hospital as, can you also stay late, take two more patients, and skip your lunch break? And so it's, how do you kind of justify or reconcile those competing demands, right? So it's really, I think on the other end of the spectrum, once we enter to practice, it's really rooted in structural dysfunction, right? You can't necessarily have time to do some of those self-care techniques if I've got 7 patients that I'm trying to care for in a 12-hour shift, right? So knowing what I can do to take care of myself when I have the downtime is important, but I think that the work environment needs to be restructured to support health and mental health and safety. One of the early things we talk about are easy things, and I say easy, it's easy to talk about, not easy to implement, are really robust staffing ratios. There's evidence out of Queensland, Australia, when they really mandated these strict staffing ratios, they saw an 11% drop in mortality and a 7% drop in readmission rates in 90 days. When we really adhere to these staffing ratios. if we don't do that, not only do our patients suffer, but the nurses suffer this chronic moral distress by knowing that they should be doing more and doing better for their patients, but being restrained from doing so. And that creates this moral conflict that it's really hard to overcome in those moments, right? We can take the time later to unpack a lot of those things, but I would like to not create them in the first place so we don't have to unpack them later, right? So, one of the things that Haya mentioned is turnover, right? And the rates of turnover are all over the place depending on which locale you look at and which municipality, but it ranges from 8% to 80% of nurses that leave their profession in the first 3 years of practice. And that's at a cost of about $80,000 per nurse for training alone once they enter practice. So the cost savings that's available to the public by taking care of our nursing workforce before they burn out is unbelievable, and would help us create longer term retention strategies if we start making those organizational changes instead of leaving much of that work to individuals.
That's huge. So let's back up because folks here might not understand what does it take to be a nurse, 2-year, 4-year, what's the commitment? You mentioned $80,000. Is that the general cost for tuition?
That's costs after training. So after you graduate and enter the hospital workforce, it takes another $80,000 to $100,000 to train you in your specialty in practice.
Oh.
And it can go upwards of 150 if you enter a specialty like the emergency department, the operating room, or critical care, where those orientations and residencies can be 20 to 26 weeks long after you get your first job.
So that's the system cost. That's not even
Yep.
the individual cost of the
Right.
school that the nurse.
Yeah. And so, that money would be better spent on some organizational and structural changes so that we prevent that cost loss in the first place and then can pass those savings on not only to our nursing staff, but to our patients.
Yeah. So what are some of the costs? I know you touched on this. I just want to make sure because I can see all of our other panelists who are like, can't wait to jump in. So just hang on. I can see your faces. So what are some of the causes that you're seeing for burnout? We've mentioned some and work-life balance and that sort of thing, but what else goes into that?
Yeah, and please, Haya, chime in at any point, but I think that frequently, it's who has designed the system, which is who it's designed to support, right? And so, we see this dual burden, especially on our marginalized nurses, those that come from LGBT backgrounds, nurses of color, immigrant nurses. Though those people, women broadly, although it's an interesting mix in nursing because women form the majority of our workforce, but many of these groups of people take additional responsibilities, don't feel like they can say no, feel like they will be treated differently if they don't accept additional responsibilities. So this dual kind of impact, this dual burden really weighs very heavily on our most vulnerable nurses, who may have already experienced moral trauma or moral distress from their personal lives, which is now compounded by the moral distress they encounter at work.
Even getting to the front door of the hospital where they're
Yep.
entering into. What are the extra responsibilities that you talked about that folks sometimes take on? What does that look like?
Yeah, I mean, so we think, a lot of the marginalized and kind of disenfranchised groups, these nurses of color, LGBTQ nurses, immigrant nurses, are typically, more likely to be caregivers for family members. They're more likely to live in intergenerational households. They're more likely to have atypical family structures where they may be caring for non-genetically related family members in their home. So they're doing this additional emotional labor, and then they go to work and have to do more emotional labor. And so it's beyond just the physical tasks of nursing, which are unbelievable. And you can really physically wear yourself out. But I find far faster than that, people wear out their spirit.
It's the story behind the story, right? It's all those things that are happening, even bringing into, the hygiene poverty and not having the resources that you need to prepare yourself for work and things like that.
Yeah.
There's something about Josh's role, and I never get it right, and I always ask you to talk about it again. So can you talk about how you know what I'm gonna say?
Yeah, absolutely. So, my primary role or a large function of my role really sits in a very gray area. So I lead the Center for Practice Transformation at the College of Nursing, which is very fancy, and it means just me. I am the entire center. But we really sit, or I really sit in the intersection between academia, clinical practice, and our community, and really looking at community in its broadest sense, right? That everyone that comes to us is our community, and we need to serve everyone. So really thinking about what are some innovative, and not necessarily with the idea, but the approach, some innovative ways we can not only strengthen our workforce, but really leverage those same tools to strengthen the rigor and quality and uplift the nurses that are doing amazing things. So mentorship is, I think, one of the most amazing superpowers that nurses have. And so that is kind of the crux of what a lot of what I do is provide not only structured mentorship to nurses that are transitioning into practice, but nurses that are transitioning from registered nurse practice to advanced practice, and providing those informal and formal mentorship opportunities. I think another big part of that is, revealing dominant power structures and how that kind of works together, and not being afraid to be uncomfortable and ask difficult questions. I realize that I am a majority minority. I am a majority in the world. I am a cisgender white man, but in nursing I am a minority. And then I'm a queer scholar that brings a really kind of different worldview, and a very critical lens, because like many of our my marginalized and kind of disenfranchised siblings, the world is not meant and built for us. So we have a unique way of kind of revealing some of those things and the power structures that aren't meant to serve us or are meant to exclude us. The thing that is completely unrelated to nursing, but was very topical this morning, was the Academy of Recording Music changing the categories of country music awards now that Beyonce has won a Grammy for country music. So there's now a traditional country music category. So just more ways to exclude people from something instead of just allowing everyone access to the same things. And that's what we see frequently, right? We see recruitment efforts go forth for, nurses, but in specific communities where they maybe want to curate their staffing pool, right? Instead of looking in the most broadly possible ways.
Mm. Yes, you mentioned something around advanced practice versus, I think, regular. Can you talk more
Yeah,
about, or
absolutely.
Haya
So,
can add to that?
yeah, and Haya, please chime in. I don't know everything about everything, Lord knows. So I am an advanced practice nurse. There are 4 advanced practices. I am a clinical nurse specialist. There are also nurse practitioners, nurse anesthetists, and nurse midwives. The other 3 are fairly easy conceptually to understand. Nurse midwives treat patients and restore them to a state of wellness. Nurse anesthetists care for patients that are undergoing anesthesia. Nurse midwives care for people that are having babies. Clinical nurse specialists are kind of in this interesting gray area. My whole life is in gray areas. So I am trained to assess, diagnose, and prescribe treatments to a patient, much like a nurse practitioner. But I am also trained in change management and social change and how to kind of shape systems. I'm also trained in educational theory, and how to structure curriculum and learning objectives. So we kind of conceptualize clinical nurse specialist practice as being in 3 spheres. We talk about the nurse, the organization, and the patient. And so I tell people that the easiest way to understand it is clinical nurse specialists take care of healthcare. That's what we do. We take care of the system, the hospital, the patient, and the nurse, and make sure that all are kind of working in harmony.
Oh,
That's amazing.
And my soapbox issue always is that CNSs are the smallest advanced practice. There are 325 practicing CNSs in the state of Michigan, but every nurse needs access to a CNS. We have a different way of seeing things. We run toward problems. I am a problem solver. That is what I like to do. So our skill set is very underutilized. Frequently, hospitals that do employ us as educators, which is great, and that's one of our skills. But there's so much more that we can do.
wonderful. Oh, such good. I think that we're setting the stage for adding in our other panelists. Haya, anything else that you want to add about ways that you support your students or things that you're seeing in the trends?
I I Josh kind of talk about the nurse to patient ratio. I think that's an important topic that we need to pay attention to because like study shows nurse with extra additional 1 patient, it may increase in 7% likelihood of dying within 30 days of admission.
Wow.
So when I read this statement, I feel like, wow, That was terrible. So I tried to find out, like in the United States, how many states they already have policy or laws saying, like clearly identify the nurse to patient ratio. And looks like there are currently only 4 states have the policy, but not Michigan. Yeah, so I feel this is very important. And from my perspective, if my students knew that they have to take care of like up to 8 patients or even 10 patients, they would be scared. I don't know
I
how,
would be scared.
Yeah.
I wouldn't know how to take care of 10 patients.
Yeah. And
So
for
yeah.
folks who are listening and might think, oh, scared because it's too much work, kind of what goes into those feelings of being scared? What are the concerns of the liability that nurses carry in a situation like that?
Yeah. I think most people think of the physical tasks that nurses do and the medications we pass and dressings we change your bed. The emotional labor is
Yeah.
significant. We try and, Haya's work is really kind of pivotal in this to use psychological safety and really detach from what we're doing, but maintaining emotional connection without maintaining a personal connection. And it is a struggle to not let things in because you want to let them in. You are a caring person. That's why you became a nurse. Um, but learning how to have just enough distance without being, abstract from the patient it's a challenge. And I think that's something that's far more of an art than a science and takes practice. Um, Hai and I have talked a lot about, we both like the idea of rituals, right? Our brains love repetition and rituals and kind of putting things in order and doing the same things all the time. And that's a lot of what those person-centric self-care behaviors are, right? It's de-escalating the same way every time. So your brain gets used to that pattern. When I was going through the beginning stages of COVID in, late 2019, early 2020, working in an ICU that was full of COVID patients, it was going back to that and doing a lot of intention setting, which is something I teach students all the time, to gear yourself up to work, and create a playlist of music that is the same couple of songs that have some significant meaning to you. But then as you're walking in the door, you have a mantra, right? And whatever it is for you, I come to work today to take care of patients, not to argue with people, not to get my way, or whatever it is that sometimes is a sticky point for you, but remembering the intent of why we're here today and kind of putting some of yourself not gone, but to the side so you can care for someone else's needs. It's a hard thing to do to consciously prioritize another person's needs over yours.
Yeah.
It is a challenging thing. And similarly, even de-escalation. When you leave for the day, another playlist of music. I had a specific candle that I would light and listen to specific music and really spend 45 minutes, during those first few months of COVID, really coming down. It was a terrifying time to be a nurse. Many of us were stripping down in our garages, and I live in an apartment, so I was stripping in the hallway, so I wouldn't even bring clothes in, and having to go through this very like systematic process so that I could get back in touch with who I was and my family. So those are the kinds of things that I think I have learned and now try and give back to our nursing students so that they are more, have that good, strong foundation and they're not like we are kind of trying to play catch up 20 years into practice.
Yeah, and one thing I learned from my students was they spend a lot of time with the computer system, with the electric health record system, more than talking to their patients directly. So just think about with one patient, they still spend a lot of time just documenting. If with 5 patients, with more than 5, there's no quality patient care.
Absolutely. Oh my, okay. So all of our panelist friends, can you see them? Folks who are listening in, you can't see this, but I'm watching them get closer. Doc G already has her hand up. She's like, let me in. So
Yeah.
Blair, if you can start letting folks in, we'll have you. So we've got Doc G and Nurse T. Introduce yourself. Most people know you, but introduce yourself. And Blair's going to keep bringing people in.
Okay, hi, I'm Dr. Gordon with Michigan United.
Tarnisa Martin with Medical.
Yes.
So Tarnisa is with Hurley, just because I think she broke up there. Then Joanne came in. Joanne, introduce yourself.
Yep. Hi, I'm Joanne Herman. I've been a registered nurse for over 45 years, and I'm with our Genesee County Health Department.
And
35
When
years.
Josh said all those years, I think I
Yeah.
added to that number quite a bit, Josh.
I think I'm number 2. Yeah.
All right. And then Cecilia.
Hello, I'm Cecilia Rutherford. I've been a nurse about 20 plus years.
And then Dr. Sulia. Stephanie, introduce yourself.
Hi, everyone. I'm Dr. Stephanie Sulia, Director of Nursing at MiCHWA Community College. Also been a nurse 20 years and a nurse practitioner for about 15. So thank you for having me.
So much experience, education. So jump in. We've talked about soup to nuts, everything from preparing students to what you're seeing in the field, your experiences in COVID. Doc G, yeah.
Okay, I want to start off with the subcultural nursing. So it's another culture that has to be dealt with in nursing. Like, we always say nurses either what?
Young.
They're young. So changing that culture within nursing as well, and then also being a Black female minority nurse, we only represent like about 7.8%, and then like 2.1% of Black African American nurses hold doctorates. So changing that dynamics, we need more diversity in nursing. So that underlying current, we know that, like you spoke of, the minorities, the racism within nursing needs to be looked at. Why don't we have more diversity in nursing? Even in leadership positions, we have Cecilia here, you have Nurse T, and myself. We are also representing in leadership positions, but it needs to be a dynamic phase change. And then speaking on COVID, as a veteran, recognizing too that during COVID, a lot of nurses develop PTSD. I witnessed myself, nurses on the floor, they come in and work, all of a sudden they take off in the middle of their shift and never come back. And so we lost a lot due to the dynamics and the pressure that was put on nurses during COVID to sustain the healthcare system. And so also going back to the patient-nurse ratio, it's not just how many patients we have. We now have patients that have higher acuity. So that means the care of that patient, it used to be a med-surg patient or a surgical patient that might have had one issue. Now we have 5 or 6 comorbidities or health conditions. So that also changes the pressure on taking care of nurses. And we know the ratio in different hospitals because we lost nurses. So the ones that are there have to pick up the slack. And of course, if you're on a med-surg floor and you normally have 5 or 6 patients, now you're expected to have 10 or 12, you're going to burn out, you're going to leave. And also you want to advocate for your patients because physically and professionally that you cannot care for that many patients safely. But what our nurses do, you need a job, you love your profession. So those are some of the things that need to change systemically, increasing, diversity in nursing. And our subculture, being more when we have a new nurse, or even when they have the agency nurses come in, they're making more money, and the floor nurses, I'm not going to help you. You're making 3 or 4 times more than me. So changing that culture in nursing and making a difference. That's my spiel. And I'll turn to nursing.
I think that too, also understanding that the nurse that's caring for the patients, they may have some of those same traumas. Mm-hmm. And some of those same concerns and fears. And then speaking as a minority nurse, some of my stressors was as far as the advocacy. I could call the physician, for example, and say the patient has a new onset of AFib and this is what we need. But I was questioned. I had to give an extensive history just to be able to advocate. And so that can be another stress that's added on too. It's already you're going in and you're here to take care of patients and you want to do the best that you can do, but you met with resistance. And so a lot of times we always hear, as an African-American nurse, that we have to be twice as good and we have to dot every I, cross every T. So before we even start work, we already working because we want to make sure that we're prepared for that day. And just the stress of the patients in general, the patients are requiring more. I remember, I've been a nurse over 23 years, but back in the day when I first became a nurse, I could easily take care of 10 patients, but the acuity wasn't as high and the patients didn't have so many comorbidities. And if it was a med-surg unit, we had med-surg patients. But now you may be a med-surg unit, but you're taking care of patients that have mental health because they don't have no beds. You're overflowing so many types of patients. So you really have to be prepared And then the documentation. The documentation now is wonderful. I love our new electronic medical records, but back then we just had some documentation as far as writing. But now the computer system takes a long time to go through that. And so when you look at those hours per patient day, they don't actually match some of the work that we're trying to provide. So
a couple of things that you mentioned that I just want to expand on. You mentioned that it's more challenging to take care of, I think you said patients with more acuity or with more comorbidities. And then you also mentioned something around med surge. Can you just expand on what those are, or why it's harder to take care, or I guess more complicated to take care of patients?
Medical surgery is a unit like patients that have medical issues, or say you had a surgery. So you have like an appendectomy, or you might have a gallbladder, or you might have something going on with diabetes. So it's like just a area. We have different units, like Dr. Josh spoke about intensive care unit. So different specialties. So like I have a specialty, a PACU, that's after surgery, and Nurse T was a manager over.
I was a manager of a med-surg unit. Prior to, I was in critical care.
So ER trauma. So it's just different specialties, and even and they're supposed to be, each area has their own nurse to patient ratio. Like PACU, you normally have 2 patients, unless they're ICU, then there's 1 patient. ER, we normally would have 3 patients, or up to 4 patients, and different units have, depending on the acuity of the patient, that's how many nurses are supposed to take care of those patients. But of course, during the dynamics of the pandemic and other issues in our organizations, those have changed. And of course, to meet the needs of the patient, there's more, the nurses have to take on more patients, which is not, safe, but what can you do at this time? So they bring in agency nurses, and that's the climate I talked about. The agency nurses are nurses that do not work for, per se, the local hospital. So they're contract nurses. So they normally come in at a higher rate of pay, but they're coming in as kind of relief nurses to help an organization that does not have enough nurses to cover. So even during this present time, bringing in agency nurses or temporary nurses is still not enough to cover the needs in the hospital. So that's where that, especially the new nurses that are coming in and they don't have their feet wet, they don't have their time management, haven't got all their, everything that, it takes a while to get your feet wet in nursing. You just don't, when you come out, you have to learn, a lot of times we have our 6th senses nursing, our gut feeling when you look across the room, see the patient's in trouble. But, it takes time to build up that confidence, build up that skill set. And now a lot of nurses are coming out and they're like fully new, and they'll have those resources. As you talked about the mentorship, usually like a nurse, you have your preceptor, but there needs also, a mentor on that unit that will help a new nurse in those tough times. So you find a lot of new nurses, or even nurses in general, don't have the resources like we used to back up, because I'm at this hall with 10 patients. And so.
Yeah, I would love to hear some thoughts from others about educational preparation. So, we talked about, you said about 7% of doctorally prepared nurses are Black or African American. And where we see that statistic, 2.1, where we see that statistic very differently, right, is in our licensed practical nurses, right? We see a disproportionate number are Black or African American. And so I think there's a great opportunity there that's where our diversity lies, to uplift those nurses to different levels of educational preparation and bring them in. I feel like, and I'd love to hear others' thoughts, that part of that, microculture you talk about, Dr. G, is we very much exclude LPNs when we say nursing, and we don't kind of include them in our family.
Yeah, I was an LPN in the military. That's at 18. So I was LPN. So I know that exclusion. I had to get into the RN club, so yeah.
So Joanne, wonderful. Thanks, Josh. Joanne, Cecilia, Stephanie, what are you seeing? What are ways that we can address this?
So one of my thoughts is we talk about self-care, because we've talked a lot about systems of care, but that self-care, and we can give a lot of examples of exercise, eating right, getting enough sleep, all of those things. We tend to think of them as self-indulgent, and the guilt that goes along with that, like putting myself before others for personal care and self-care. And I know it's a topic that many of us struggle with. It's easy to preach that. We advocate this behavior for our patients, to have healthy lifestyles, and we teach our patients, many of those tips and tricks of how to be successful. But how many of us are actually practicing that in our life? And, I did some self-reflection on this topic. So how do I do? Am I doing okay in that area? And maybe at times I am, and many times I'm not. So I think it's something that it's a journey. It's a journey, and it's not self-indulgent to take care of ourselves. We're talking about the systems of care, but also that personal care that we need to be mindful of as well. So thank you.
Absolutely. Cecilia.
Okay. I'm going to bring another perspective to the table because I had an opportunity to work in another perspective world. We have to understand we can fix everything we want to with nursing. First of all, everybody listening to be a nurse is a privilege. I thank God for nursing. I love taking care of patients. We have created this dynamic for ourselves as burning nurses out in the workforce. One of the things I did when I was a vice president of nursing at Rochester, my nurses was important to me. And let me tell you why. Team nursing was the original model for nursing. We went to primary care because we got RNitis. Michigan has this thing about education. You have to have the highest degree to get this job. We have to understand team nursing. We will never fill the gap for primary care nursing in 100 years from now. We can keep talking about we need nurses, we need nurses. I always told my team, stop saying you're short nurses. Don't even think about a ratio. Think about how you can care for your patients with whoever show up today, because that's how bad COVID got. Because we can spin our wheels all day trying to give one nurse 10 patients. Why not bring a nurse, a LPN, and a CNA in? I'll do the assessment as your RN. I want your LPN to pass your meds, and then we will all give the patients baths. We have to think about nursing in a different model. There is no way we're going to ever catch up with what we lost. One of the things we need to look at as instructors, Stephanie, I challenge you to inform your nurses that you have to have a contact. You got to work for people that care for you. If we don't fix that manager piece, I was a nurse manager for years. You're smashed between your staff and the C-suite. And if you never walked in the manager piece, those tend to be the people in the C-suite who's never done this work. It is a lot of work. There is no way a manager can care for nurses without first caring for herself. And if I didn't learn anything else being a manager of nursing, a director of nursing, a VP of nursing, every place I worked, I had a 5% turnover rate. I had a 5% recruitment rate because people don't come to work. They come to work for their boss. And if your boss not rooted and know what you need and can king in with you, you cannot lead nursing. And what happened is nurses want to stay on this soapbox about staffing while operation is making decisions. So the people that's making decisions for nurses are not nurses. So that's why I went into operations, so I can sit in a room with a room full of CEOs, VP of operations, and when it's come to making a decision, if you're not taking care of the patients, take care of the people who are. So what did I do? I work for a national team. I got on a lot of the national work with Ascension, and I was asked this question in 2021. 10 tips for caring for yourself and your team. Self-control. Be patient. Serving others is a form of self-care. Develop a positive mindset. Start journaling healthy habits for self-reflection. In my hospital, everybody had a reflection room. When my nurses needed a moment to get some air, when my nurses needed to sit in a chair and get a massage, I was fortunate enough to have a room where they can go and reflect and care for themselves. Create a self-care monitoring routine. That's what you did, Joanne. Mm-hmm. Schedule quiet time for yourself. Learn how to say no to activities, things that don't serve you or your family. Get comfortable with asking for help. It's okay. I need you to help me. Create a self-care basket. All of my nurse leaders had a basket on their desk, and I wrote in there, I gave them positive tips. Maybe take this stress ball. Remember, I need you. You're part of this team. Be organized. Plan out your days. And every last one of my nurse managers have the schedule a self-care appointment on their calendar, and I will look for it. Because if you can't care for yourself, You cannot care for these nurses that's under you. We are going to have to get into operations, nurses, because if you want to change, you want to look at the patient ratio, you want to make decisions, you can't make it sitting in the nurse seat. You got to get into operations, because operations say, yes, that's how much money we got. As a nurse, we can make it happen. Because guess what? If you don't watch your nurses, we'll come up with our own pack. You'll be looking for things we'll create. But that's because we haven't had the resources, because we spent all day talking about what we don't have. We have it. Get in the right seat. I challenge nurses to get in the operating seats, to make decisions. That's who make the decisions, the operators. I'll stop.
Oh my.
Stephanie, thank you. I'm a mock grad.
I hope everyone was able to write down all of those areas, or if we can
I'll
get
send it to you.
That was amazing. Yes, I know Stephanie is itching because she deals with students and steps into this, but we'll come. Okay, Stephanie, come on ahead.
I was going to say, I don't know if I want to follow that. That was amazing. Thank you for all that insight. And it's a great reminder for me as a leader of the 60 faculty I work with. You know, if your faculty are not, you know, taking care of themselves, then how can they, you know, also help take care of our students and support our students and help, you know, the importance of, you know, in my role and in roles of faculty as demonstrating self-care and demonstrating, you know, some of those important, you know, habits and skills and things to develop to help these nurses come into the field, right? And so, you know, once we start to exhibit signs of burnout or of, you know, not, you know, getting tired or, you know, negative speaking about being a nurse and things like that, then it just permeates. It permeates into our students and permeates, you know, across our community. So that was, you know, my initial thoughts of, you know, the importance of me as a leader taking care of myself and then helping our faculty lead this next generation of students. And I do think I love being at a community college, and I love a community college student because our students are, you know, we often say non-traditional, right? So a lot of our students have all of these complex situations in life. You know, our average age of our student is 35. You know, it's not just coming right out of high school. And there's so many things that our students face with challenges, barriers. I met with a student this week who doesn't have food to eat or feed her family. So simple things that feel simple to me, but you know, what a challenge that our students face, and the majority of them overcome. But I see that so much of our role in a community college is just helping our students to be equipped to complete our program, be the best nurses that they can. You know, the benefits of our students have so much clinical experience. Our students at Mott, we get 920 hours of clinical experience. So they are there on the unit. They are prepared, more prepared, maybe not 100% prepared when they leave, but more prepared with that experience. So definitely we've incorporated many of our faculty. I have one faculty I can think of who her doctoral work was in.
Oh, I think we're left with a cliffhanger. I think Stephanie oh, there she goes.
Oh no, there, I'm back. Did you hear that? One of our faculty, her DMP project was journaling. So all of our students, when they start our program, are given a journal, a self-reflection journal, encouraged to journal post-clinical, journal, you know, what they're doing throughout, you know, what they're feeling, how they're feeling, things like that. So that's another amazing tool that, you know, that we help to provide our students. And I do think Mott does a great job. We have, you know, care teams, counselors. We have a big support system to help our students be successful. So I think that's an awesome tool. But thank you. I'm inspired, Cecilia, by your thoughts, your advice, all of that.
Yeah. I'm inspired when I think about Mott, because I graduated my ADN and Mott. One of the things I would like to see, I haven't been in Mott in a long time. It was the hardest thing I ever did in my life was graduating from nursing school. And it wasn't the program.
Yeah.
It was the treatment. And I pray and hope you bring in a different set of eyes.
Yes.
If not, tap into them students, especially students of different backgrounds, different culture. When I tell you, I struggled, and all I wanted to do was look at an instructor that looked like me, and I didn't get her to the end of my career, end of my classes, and it encouraged me. People look like me. I was 4 kids in, 4 children trying to go back to nursing school.
Yeah. Wow.
I went back to nursing school with 4 kids, too much. And I remember crying the entire summer at the treatment. And it's not an outlet. So I pray you have an outlet and a safe place and psychological safe for those students,
Yes.
that they make it, And I am opening up my mentorship along with Josh.
Yeah.
I am here. If you need a place where they can talk, where they can be encouraged, because that's the encouragement. Nurse T, Dr. Gordon, we're all here. Things that we need to do to improve things should not cost us money. It costs us our time. It's part of who we are. We need to have set up a mentorship for those nurses that's coming through that don't have food, that don't know how to do a budget, but want to finish nursing school. And what do that look like? I'm offering myself up, and I know I can call these two on the bottom of my screen, Nurse T and Dr. Gordon, in 5.2 seconds, and they'll do it.
Yes.
Yeah. No, I appreciate that. We definitely need to connect and provide that for our students. I do hope and I feel the culture's better than what you had, and I'm definitely striving to make it better. So thank you for sharing that.
Thank you.
Yeah. I just wanted to say, everybody have been phenomenal. Thank you, Cece. That was but I want to say one of the reasons why I wrote Your Health Matters Too, because it had to be a personal message to me. Because when you're passionate about providing care and like being a manager, you're passionate about your staff, you tend to neglect yourself. I was a manager for 12 years over a very busy med-surg unit. And a lot of my nurses' pain, I took on. Their anxiety, I took on. It was so much so I was out there, yes, doing the operations, the day-to-day, but I wanted to make sure my nurses was good. But sometimes, the patient load, what they were going through, that in the midst of all of that, I forgot to take care of myself. My staff would be like, boss, don't you gotta go? Don't you got a doctor's appointment? And I would be like, you know what? I can reschedule that doctor's appointment. And then I kept rescheduling to the point that it was almost too late. So I had a near scare. So one of the reasons why it is very important and to understand why we are not prioritizing ourselves. A lot of times it's procrastination, it's people pleasing. We think that it's selfish for self-care. It's just a lot of things, but also just making sure that us as healthcare providers, we have to know that we have to keep our cup filled. And when we pour from an empty cup, that cup begins to crack. So just making sure that we all know that our healthcare matters too. Us going to the physicians, us making our appointments, because if we're not healthy, and then we can't be healthy for the patients that we're taking care of. We can't be healthy for the staff that we're trying to mentor. We can't be healthy and show up for the organization. We show up for everybody. So let's start showing up for ourselves. So now that we can show up for them and build a healthier community, patient and family-centered care, and leadership of nursing.
I'd like to chime in on the mental health piece. I'm also in the school for psychiatric nurse practitioner. I'm almost there. But I also have a mental illness. I have PTSD that showed up during COVID. So, of course, that's a stigma with mental health. No one wants to talk about it, especially, you're a nurse, you got some mental health issues. So making sure it's okay not to be okay, and taking care of our mental health as well. Like incorporating all those things is basically taking care of our mental health and rooted in that.
Yeah. To kind of piggyback and continue on, I would love to bring in Haya, please chime in, an international perspective. So I recently completed a bunch of literature review about resilience and nurse burnout for a journal club that I'm helping host for a health system. And there is a dearth, or there's not any really published information about nurse mental health outside of the Western Hemisphere. And so when we dig in and start to look at it, it's many of those cultures just don't have this problem because they treat their nurses very differently. And they lean into, as you know, Ms. Rutherford was talking about, a team-based, patient-centered care model instead of a primary nurse-driven model. They are community health, primary care focused instead of quaternary care focused. And so we as a culture have really set up and perpetuate this problem that we don't see in a lot of other places in the world. So I think it's interesting that for sure.
So I want to return and perhaps we have nurses that are listening in. There are maybe students listening in. Cecilia, what would you recommend? How would someone go from maybe a student, maybe an RN, LPN, and they have their eye on moving closer towards that C-suite, right? Moving closer towards that decision making. What are some things that they should be thinking about? We know that they should make a phone call to you and the other folks here. That's a given. We've already got love from someone to you in the Q&A who says that you are a wonderful mentor. But really, what are some practical ways that someone could elevate themselves?
Well, one of the things we do in healthcare is the best nurse we think, well, oh, she's such a great nurse, let's make her a manager. Mistake, my biggest mistake I ever made in my career. Leadership, if they want to be developed, if they're a floor nurse, give them a project. Lead the infection control team. Lead the staffing team. How you going to show up today? Ask your manager, is there any extra work I can learn? I want to be a manager one day. Let your boss know your goals. Because if we're in the right seat, one of the things we have to do as leaders is I work to give my job away. I'm not working to stay here. You work to say, who can I bring on next? I can walk out in a clinic and say, okay, where's my leader in this clinic? It's the ones that show that zeal and that assignment. And we as leaders should be looking at our team. It might be the shy one in the corner, but she might can get a project done in 5.2 seconds. And then you reevaluate. New nurses they deserve a 30, 60, 90-day check-in. If you are a leader and not checking in, and then I wrap it around with a 180, if they've been there a year, you should know. I knew my nurses knew they had kids. When is the next basketball game? I wrote little notes on my computer. So look out at your team and let them do a self-evaluation. What do you see yourself for 3 or 4 years? And connect them. If you're in a hospital system and you're not connecting your floor nurse to her next assignment, shame on us. Because I can't work. I plan on retiring at retiring date. And right now, I got my eye on who can sit in this seat because I'm bringing her along. That's what we do as leaders. We bring people along and you coach them and you lead them. And then you got to build that trust and give them an assignment. But go to school. If you want to get in leadership, go back and get your bachelor's, your master's degree. Once you finish go back. And then when you just keep elevating yourself and then trust and believe in yourself because you're going to get a lot of no's. Mm-hmm. I applied for one job. I got 8 no's. But I never stopped applying. 8 times somebody told me I wouldn't qualify to be a director. Now I've been a manager for years. 8 times I put in for a position. But I didn't give up on myself because I knew what was inside of me. And I knew my assignment. I have to have a voice for healthcare. And you get a voice, but unfortunately you got to be in the right seat so you can speak to it. And then you just keep going up and trust yourself.
Ooh, excellent. Yes, we saw look at Nursty. Yes. Did you have something else to add to that?
Oh no, I just want to uplift Joanne. Is she still on here, Joanne?
She had to step aside.
Oh,
she
okay.
had to step out.
Yes, that's speak like Cecile was talking about finding someone like to mentor. And Joanne, as you know, in my role I got my doctorate right at COVID. My role as a director, Joanne was my mentor, and she still is my mentor. So finding those nurse mentors that's been there. She's a VP of Genesis, and Cecilia also does great talking about the barriers that there are when even though you got the degree, you have the same thing when you have a doctorate degree, highest determined degree you can go, years of experience, and there's still barriers that you face, but just continuing on and the right seat will come. That's why I thank Michigan United for the opportunity of leadership.
Yeah. Stephanie, I have a question for you.
And Helen.
Oh, for you. I know my college have women in education does mentorship because I have a couple nursing mentors, but do the School of Nursing have a mentorship program to help the students through like the Women in Education?
So I know a couple of my faculty are mentors through the Women in Education, and they work with nursing students. We do have a couple other like internal mentorship. So the second year students, we have a mentor program for first year students. So we have that. And then we have a faculty mentorship program for readmission students because we know when they come back, they're at risk of not being successful again and not completing. So we have, that type of mentorship. So those are the kind of more internal mentor programs that we do. Do you have some other great ideas?
I was just thinking, would you be open to a panel of nurses coming in, sharing some of their barriers and their concerns and how they overcame them? Like I started at my college as well, but then I transferred over to U of M. So I think that if we could have a panel, a diverse panel, and being able to address some of the traumas, the concerns, the fears, and with real life experiences and testimonies, and also letting them know that there are resources and that the people that they do see on the floor in leadership or in C-suite positions, they had to overcome some of those same barriers. But like how Cece said, but we didn't give up.
Yes. Yeah, I think that would be amazing. We do have panel like current students with new students and things, but I would love that so much. Let's do it. I can think of a bunch of different opportunities for it. So please, let's connect and we'll figure that out.
I love this part of the webinar. Oh my God. I mean, folks, you're watching innovation happen right in front of your eyes. You're watching the future and the future health of our community happen right in front of your eyes. How exciting and how wonderful to see this unfold in front of us. We have rounded out this conversation. I would like to give everyone a chance to add their last 2 cents. We only got about half a cent. So if anyone wants to just kind of add your last couple of words, we would love to do it. And then we'll wrap up this wonderful hour of conversation. Anything that you want to add that we've missed?
I just would like to know how to make soap with the leaf and the oil. She can call me. That's all I want to do is make soap.
I love you. I love you.
And if
I
you're
was
nursing,
curious. Go ahead. Yeah. I was just curious, as it's kind of come up, how many of us, because I am a very proud associate degree nurse as well, how many have started with our associate degrees?
I started as an LPN in the military,
Right.
then my associates through mine.
Yeah. LPN and mine, I ran through mine.
Yeah. So never stop, just keep striving, keep going one class at a time. And like she said, if you want higher education, like say one class at a time, one program at a time.
Yeah.
I'm a proud product of Henry Ford Community College. I learned so much, so much.
Yes.
Yeah, I love my college. I started, my career there. Mine was different. It took me 10 years to learn how to become a student, because when I graduated high school, my GPA wasn't there. It wasn't that the smarts wasn't there. I just didn't prioritize myself. But Mott gave me that great foundation, just to be able to transfer. So I'm one of those students that's like, don't give up. Yeah. You can get there.
And Dr. Mopar, I like to give her a shot. She used to be at over Mott, and she's the one, I transferred. I was LPN, and I need to get to the transfer program, and she gave me my chance at Mott. So having those people in those positions, leadership, willing to give students a chance, 4 kids, like Nurse said, I think it was a shy point away or something like that, and give the chance to work through those things. And I'm my baby too, but starting the military.
Yeah. Me and Cece hired in at Hurley together.
Oh.
Yeah. And I work with Cece at Ascension. Yeah.
Awesome. I love this. What a wonderful conversation. I want to just remind our folks of some events coming up that we want on your radar. Of course, we know that you've been anticipating the Healthy Flint Research Coordinating Center's 2025 Research Symposium. We want to see you all there in person. This year, they're focusing on the role of citizen science, so you'll be hearing more about this, but save that date. It is Friday, September 26th, in person at Riverfront Conference Center. We want to see you all there. And then there's also a Unity March coming up. Saturday, June 28th from 11 to 1 p.m. They are looking for volunteers. They're looking for participants and supporters. You can see all of the folks there that are going to be there. Critical that we show up, show out for this important work. And as always, don't forget, CHWs, we've got you covered. You can get that CEU right here on the webinar. So make sure you fill out the survey that's going to pop up at the end. Next month on the webinar, we're talking multiple myeloma. So stay tuned and we'll see you all then. Thanks, everyone.